And in the end, I will ask those panel questions.
Yeah, fine.
Dr. Prashant, you can start.
Thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. Doctor, this program is brought to you by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company with 25 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, API, and FDFs in the world. Hetero Healthcare is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. A 360-degree solution provider, Hetero Healthcare strives to fulfill unmet healthcare needs, reaching out to customers across India with wide product range encompassing multiple specialties, pioneering in both quality and innovation. And Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program Managing PPH, we have got Honorable Speaker Dr. Batul Wadiwala. Welcome, Madam, to this program. Dr. Batul Wadiwala is gynecologist and laparoscopic surgeon, Himmatnagar. Madam is proficient in conducting normal labor, cesarean section, and managing critical obstetric deliveries and performing advanced gynecological surgeries, including laparoscopic procedures. Dr. Batul is skilled in antenatal sonography, TIFFA scan, 3D and 4D sonography, has extensive experience in conducting both normal and critical obstetric deliveries, cesarean sections, and managing high-risk pregnancy. Madam is MBBS from SBKS Medical College, Vagodia, Baroda, DGO from College of Physicians and Surgeons, Mumbai, Fellowship in Advanced Gynec Laparoscopy from Motherhood IVF Center, Ahmedabad, and Dr. Batul is government empaneled laparoscopic tubal ligation surgeon and family planning. Over to you, madam. I'll run the slides.
Thank you. Thank you so much, Dr. Prashant, for such a nice introduction. And sorry for delay to join for some technical issues. I must say, Carbetocin will never delay in PPH management to give an excellent result. So here, without wasting much time, I'm going through the slides a little fast. So we all knew about PPH. So I did not say much, but what is the normal situation? The blood flow is less than 500 to 800 ml. In PPH, there is a loss of uterine contractions. So the blood loss is more. We encountered that it is a PPH. So we have to manage it with the drugs. We first see for the cause of the PPH. So next slide, please. Yeah. So why it is yet uncommon? The incident we see in worldwide, so in a maternal mortality, so more than 35% of maternal deaths occur due to postpartum hemorrhage after the third stage of labor. In that, we all want to decrease this MMR rate, but yet in the developing countries it is more than 240 per 1 lakh live thousand, 1 lakh live births, and in developed countries it is lesser than this. It is a 16 in 1 lakh live births, right? In a globally, it is 14 million women suffer from PPH, and incident is reported is 2 to 4% after vaginal delivery and 6% after cesarean section. And in India, it is 38% of maternal death due to PPH. In that, 25.7% of global deaths like place in India, and in India, it is 2/3 of this attribute to PPH. India is unexpectedly high maternal death rates due to so many reasons. Most common is low socioeconomic status, anemia, likely. So the etiology, most important, we have to see the cause of PPH, postpartum hemorrhage. So it may be atonic uterus. There is a trauma, so traumatic the cause. Third is the retained product of conception, And lastly is a coagulation factors defect, thrombin. Next, please. Okay. So clinical findings, we always need to see the vaginal bleeding, then maternal tachycardia, most common and first to diagnose, abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contractions. We have to manage patient. We have to see after delivery of the baby and placenta, vitals of the patient. With the vitals, first we encounter the patient is in a shock or not. So we have to monitor that if she is in a shock or the bleeding is more, then we have to see the amount of blood loss, the 1,000 or 1,500 ml. Patient, if patient is complaining weakness, sweating, tachycardia, so we encounter she is in a shock. Then we have to manage appropriately. Next, please. Okay. So initially, rapid assessment of patient status, what I said, then tachycardia and hypertension, and loss of blood amount of blood, how much she lost. So according to that, we have to manage the patient. Examine at the time of the hemorrhage, the assessment of entire genital tract lacerations. So what again I said before, we have to see for the cause. It is traumatic, atonic, retained product, or any coagulation factor defect. Next, please. Okay, so the appropriate treatment is according to the cause of the patient. If patient in atonic uterus, so uterus is not well contracted. To manage this patient, we have to give her uterotonic agents like oxytocins, prostaglandins, ergoalkaloids. If she is not responding to our medical management, then we have to go for the surgical management. Second thing, if it is a trauma, a vaginal trauma or laceration or cervical tear or anything like that, we have to treat her accordingly. Third is retained product of conception. If there is any placental clots or retained products, so we have to remove it. And then to give a massage or thorough massage to the uterus, and with the management with the drugs of uterotonics, the uterus will going to contract. And if there is any coagulopathy, so we have to encounter with the coagulopathies, we have to treat her accordingly. So this is the most important slide is here. Why nowadays carbetocin is more preferable by the doctors. So more suitable its use now because it's available in a room temperature. This stable at formulation and conventional vial presentation. Oxytocin and ergot alkaloids should be kept below 2 to 8 degrees. We all knew about this. Its formulation and its storage. That is quite difficult for us, and most importantly in our rural places where the cold chain we cannot manage. So in this type of cases, now we have carbetocin at a room temperature formulation, and longer half life. It is is equal, almost equal efficacy of oxytocin. So it is a better choice to choose carbetocin. Okay, the uses of other uterotonic agents. So when we can give it, time of administration, that is the first to crowning of the baby's head, delivering of anterior shoulder, or second stage of labor, and following the delivery of placenta. Prophylactic use, prevention of PPH, and active management of third stage of labor, and therapeutic management of the PPH. So we can use oxytocin, carbetocin, ergometrin, symptomatrins, and misoprostol. These are all the uterotonic agents we used normally after the delivery of the placenta to manage PPH. Carbetocin, a next generation drug for PPH management. Carbetocin is created by making several modifications to the oxytocin we all knew. It is a synthetic long-acting analog of oxytocin only. Therapeutic indication is prevention of postpartum hemorrhage due to uterine atony. And posology of administration, one vial contain 100 microgram of carbetocin in 1 ml solution for the injection. Ideally, we are giving in 100 ml of normal saline IV or directly IM. So, in mechanism of action is it is analog of oxytocin only, but it has its longer half-life. Receptor binding triggers activation of phospholipid C and the generation of the second messengers IP3 and dicycloglycerols. IP3 induces release of free calcium from intracellular storage. How it acts? It acts on the uterine muscles, and it like oxytocin only. It acts on the oxytocin receptors, and it frees the calcium from intracellular storage, and it binding the calcium to calmodulin stimulation uterine. It stimulates uterine smooth muscle, and contractions occur. And uterus is contracted by the activation of myosin light chain kinase. A single IV dose of carbetocin, 100 microgram administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony and excess bleeding, with efficacy compared to hours of oxytocin infusion. Carbetocin clinical evidences is there. WHO has already have a trial, champion trial. But before that, we are talking on oxytocin and carbetocin. So we all knew about its major differences. Oxytocin's half-life. Oxytocin is a very short acting, and carbetocin is a longer acting. Intravenous, if we are giving oxytocin intravenous, it is a 30 minutes of half-life, and if we are using carbetocin, a 60 minutes of half-life, almost double. And in IM route also, if oxytocin is half-life is 60 minutes, then carbetocin is acting on 120 minutes. It is also same also a double. Yes, of course, we can not use carbetocin to augmentation or induction of the labor, but this is the carbetocin is used for the after delivery of the placenta to prevent particularly PPH, postpartum hemorrhage. So this is the WHO champion trial. So study design, it is a non-inferiority double-blind randomized trial to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patient of more than or equal to 30,000 women across 10 countries, including India. And outcome is the proportion of women with blood loss of at least 500 ml or the use of the additional uterotonic agents, and proportion of women with blood loss of at least 1000 ml. Trial is already conducted, and efficacy and safety is almost equal in oxytocin and carbetocin. So here the efficacy and the safety is almost equal, or carbetocin has some more, I must say. So the conclusion of this study is carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. There is also a Cochrane review, and the review said same. For the woman who undergo a cesarean section, carbetocin resulted in a satisfactory significant reduction in the need for therapeutic uterogenic compared to oxytocin. Also, carbetocin is associated with less blood loss compared to cytometrin Symptometry in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Guideline recommendation, yes, there is WHO, the champion trial, we already talk on that. SOGC Canada also said that Carbetocin 100 microgram IV bolus is safer to use after delivery or C-section to prevent PPH. New Zealand also, Renskog also said active management of third stage of labor and use of prophylactic uterotonics. FIGO said Carbetocin, one of the recommendation for PPH management. Germany, Australia, Swiss also said like same like Canada is saying Carbetocin 100 micrograms slowly IV infusion is prophylactic for the PPH management. And SCOG France is saying the guideline Carbetocin on proving non-inferiority to the oxytocin, as like WHO said in Champions trial. So yes, my experience, I have a number of cases, but here I'm just saying 2 or 3 cases. So my first case, 25-year-old female, primary gravida patient with 38 weeks of amenorrhea presented with spontaneous onset of labor. On examination, presentation is normal, cephalic presentation, fetal cardiac activity is normal. Her BP was slightly raised, so I encountered she is in a preeclampsia, a gestational hypertension with proteinuria. Augmentation of labor has been started with the oxytocin infusion. On the blood investigation, I have seen that she is having a thrombocytopenia. Her platelet count was just only 71,000. So in this case, we cannot use methyl ergometrins as she is a case of preeclampsia. And in this case only, I cannot use, I actually do not want to use prostaglandin because I have to give it in intramuscular, and because of her low platelet count, there is a chance of hematoma. So I have used in this case, I have started augmentation with oxytocin, and after delivery of the placenta, we have given a single 1 dose of Carbetocin in 100 ml IV. Without any complication, no bleeding at all. We just fastly sutured the episiotomy, and without any blood transfusion, we have discharged this patient in within 48 hours. So it was a really good experience, and I just remembered this case because it was my 3rd or 4th time when I was using Carbetocin. Another case is a high-risk pregnancy. She was a 36-year-old female, second gravida patient with previous 1 cesarean section. She was a known case of diabetes, and she was having chronic superimposed hypertension. Already she was on the medicine of hypertension, and she conceived after 3rd cycle of IVF. So it was a precious pregnancy. She was having diabetes, she was having hypertension, and her weight also 113. So her BMI is in obese already. After crossing the age of viability, we have performed elective LSCS on her. As in this case also, we cannot give methyl ergometrins. We do not want to shoot her BP. She's a case of postpartum hemorrhage, more likely because diabetes, hypertension, obesity itself. Another thing is the case of IVF, very high risk pregnancy. This all says us and prompt us that she will undergo for the PPH. And yes, she end up in a PPH, but we have started Carbetocin 100 ml state we have given during operation. After the massaging of the uterus, it once it get contracted, then I did not feel any episode of relaxation of uterus. So it was a very good case, and uh, actually it worked very well in this case also.
Thanks, madam, for sharing your cases. They were really interesting, especially that patient was overweight and really it controlled well.
Yeah, it
Yes,
really controlled, because we also do not want, actually in this patient we have pre-planned a 2 unit of blood in the OT, because
absolutely.
we actually thought that this patient might encounter with PPH.
Correct, correct, correct.
We counseled to patient and relatives prior the surgery. We may end up to
Yeah,
do
yeah.
a hysterectomy in this patient, but luckily, and with the use of carbetocin, nothing has happened.
That's the beauty of our science, where we expect now it doesn't happen, and where we don't expect, suddenly we'll end up in something. Some few panel questions, madam.
Yes.
What is the pressure patient profile? In fact, you have described one patient profile where the doctors can. I don't want to waste your time on this, madam. Can a doctor use your experience, madam, in case of retained placenta?
See, what I have said before, that we have to see for the cause first.
Correct.
If there is a attorney, carbetocin act very well on that. But if there is a retained product, we have to remove it first,
Yes, yes,
then
yes,
give a
yes.
carbetocin.
Correct. And because possibly because it contracts the whole uterus, it would
Yeah,
work.
the so product will caught inside, it will
Yes.
get infected,
Correct, correct.
septicemia, again PPH, anything can happen.
Yes, yes,
So we
yes.
have to remove the cause first and then treat.
Any experience in RH negative mothers?
Yes, this is the drug what actually made for the RH negative mothers also, because we cannot give methergine to them. We
Yes.
do not want blood in the mother circulation. We do not want tachycardia in that even. So this is the safer drug to use.
In fact, both the cases you showed, the methyl ergometrin was almost contraindicated with this
Yeah,
hypertension and
yes,
yes.
it is contraindicated. We should not use it.
You have used, I mean, the case that you showed, second case, you have used oxytocin for induction and then carbetocin. It works well, madam, na?
Yeah,
Generally.
in a first case,
Yes.
yes.
What is the route you generally prefer, madam?
Generally, I prefer IV route, because patient already admitted. We have
Correct.
a
Correct.
cannula, so IV is better to give on IM. The effect is slower in IM.
Yes.
Another thing is, if you are if in a haphazard form you are doing delivery or C-section, so must be IM is given by your staff. If
Okay.
it is
Correct.
not going in a proper route, even it will
Yes.
not work. Other thing, if a patient is having short of some coagulopathies, or blood investigation properly not done, or something wrong, there will be a hematoma or anything
Hematoma.
else. You
Yes.
will encounter the other problems.
Yes.
So
Correct.
better to use IV. If
Anyway, they have
patient is in a feasible, proper hospitalization and feasible environment.
any adverse effect. How long you have been using carbetocin, madam?
Almost 8 to 9 months.
Oh, it's quite
Once I have started, then I
no
don't
going
think
back.
so. I have stopped it.
And any adverse effects you have seen?
No, not much.
Not much.
Mm. Not not like methergine, methyl
Yeah.
algometrins. It shoots a BP like 200, 210.
Once upon a time, in my time, we had oxytocin and methyl ergometrin. I mean, in my time, I'm talking.
Yes, yes.
Yes. If suppose if the patient doesn't respond adequately with carbetocin, then in what order of preference you would use other eutotonics? It can very well happen sometimes that carbetocin doesn't work.
Yeah, if of course not, if carbetocin does not work, we use prostaglandins.
Prostaglandins.
Yes, if prostaglandin does not work, of course, if carbetocin not work, we have already started the infusion of oxytocin
Oxy.
already.
Yes.
If we are encountered it in a C-section, we can give oxytocin or methyl ergometrins intramyometrium also,
Oh, yes, yes.
right? if
Ambika, very nice.
no medicine going to work, then we have to do our surgical
Yes, that
procedures.
is the last. Yes.
Okay. So a stepwise evascularization of the uterus we have to start.
Advantage or other uterotonics? Of course, the storage and single
Yeah,
dose
that
is
is
an
the bigger
advantage.
benefit now we have. Uh, it's heat,
Stable.
yes, heat stable effect, and other advantages what I have seen it is not like shooting up the patient's BP.
That is important.
Patient,
Yes.
the tachycardia and high the respiration is also we cannot see in the carbetocin,
Carbetocin.
right? And
Yes.
if we are using prostaglandins, carbetocin, the other side effects are like nausea and irritable bowel, patient nausea and vomiting. Uh,
And
yes, it is more and more safer in asthma also.
yes, yes, prostaglandins we can't use there.
We cannot use it.
We have been using it as a first line, of course. But there's
Yeah,
no question of keeping
of
it as a
course.
reserve. Yes.
Nowadays.
Yeah, exactly. And anesthetists and gynecology role, especially in big hospitals, big setups.
Anesthetic तो अपनी करता है. But yes, of course, nowadays I even see the anesthetic also using because they do not want to monitor beeping fast for the
Yeah, yeah, yeah.
systolic and diastolic is raising.
In fact, in one of the webinars, when anesthetist told me, I will use this and I'm relieved. I can go to the other room.
Yeah, they
Yeah,
can
that's
go
exactly
and they
correct.
can relax even while
Yes,
surgery is going
correct.
because they know that in a preeclampsia, sometimes, of course, sometimes if uterus
Yeah,
is not
yeah,
going
yeah.
to contract, then I
I'll say
cannot
so. Yeah.
say it, but some of the time they have used the methergine if patient is on a stable condition.
Correct, correct,
But
correct.
carbetocin acts very well. We do not use it like.
Well, overall, your take-home message for the audience.
Yes, it is a first line drug. So we better to choose now wisely for the patient and for us even. Uh, its cost is not that much high that we cannot use and patient cannot afford, but it is a very safe drug to use, and there is a less than 1% chance of PPH.
That's very important. Yes.
That's very important.
Yeah.
Life-saving drug is then we have to use it.
And I always say PPH is a wonderful topic to discuss and debate, but worse to see a patient. One
Yeah.
should never see a patient.
We never see it is a nightmare for the
I
gynecologist.
can understand. Thank you so much, madam, for sharing your experience. It was lovely. I'm sure the audience has benefited out of your experience. Thank you so much.
Thank
You
you.
can log off, madam. Thank you. Wish you a very
Okay,
pleasant
thank you.
afternoon. Thank you.
Thank you. Thank you.
Thanks, Bivas. Thanks, Sanjana. We can log off.
Thank you so much, ma'am.